have a patient portal now, an interface that is patient, maybe on a mobile app on that side as well. The impact of this is, one, to improve patient health literacy, so that if you went to the hospital and were diagnosed with a urinary tract infection, then you leave understanding what a urinary tract infection is, how to prevent it, if it can be prevented, why you were given the meds you were given, why the tests that were done were done. It also reduces the workload on the clinicians, because assuming you have 100 patients on your queue and you have to explain to each and every one at the end of the visit what the encounter was all about, there is fatigue from that, there is risk of you skip that step, so this kind of handles that for you. So on to my last slide. Concern areas in AI for health. Majority of this has been covered by previous speakers. There's always the issue of data, garbage in, garbage out. So if you have an incomplete data set or biased data set, or you are not even collecting the data in the first place, then there's nothing to build the model on, right? There's privacy and security. In my last scenario, I've just described a scenario where we potentially are sending patient level information to a model. So how do you handle patient privacy, patient security when handling personal health data? These ethical considerations. One of the biggest conversations in artificial intelligence is usually explainable AI, where you can be able to say or trace back, why did the model generate this response for this question? Can we follow through its sort of reasoning process? So that's always a concern area. And then potential for AI-driven discrimination or unintended harm. I think this kind of ties on to regulation, governance, compliance. Is at the end of the day, if the model makes a mistake, who is responsible for it, right? And of course, if you can imagine, health is really not one of the areas where you want any mistakes at all. I see people in finance bragging about model accuracy of 60 and 70%, and they're very proud that my model has been able to achieve 60%, 70% accuracy. That's not something you can be proud of in healthcare. A 0.1% misdiagnosis we're messing with someone's life, right? So we also have regulatory and compliance, which is unclear or evolving regulatory landscapes. I think from Ambassador's presentation, and then from the lawyer, the one who said he has a law background, I forget his name. You can understand why regulating artificial intelligence is a challenge. I understand why it's a challenge. We're left sort of in a limbo. You don't know, there's no law to guide how I'm doing this. So I'm hoping that when I do it and explain why I did it and how I did it, that it will make sense, right? Of course, following global principles around safe AI, that is responsible AI, inclusive AI, explainable AI, all of those principles. We're following that, but at the end of the day, we don't have a law in Kenya that governs how to do what we do. Then integrating with existing systems. At the end of the day, these AI tools need to be hosted, or they need to run somewhere. So these AI tools need to be integrated into existing either clinical workflows or into existing systems like the National Health Information Exchange System. And then lastly, there's issues of sustainability and maintenance. AI right now is currently very expensive, and it's not only expensive in terms of compute resource, which is hardware resources. It's expensive as electricity, hardwares, the people who need to be able, the human resources behind artificial intelligence. And if you need to keep monitoring and updating and building more and more and more, it's okay, at the end of the day, where will all these AI models go, or where will they run? So those are the key concern areas. I chose to call them concern areas rather than challenges, because some of them have a way around them, like there exist solutions for some of them. But yeah, it's just something we always need to think about when we're thinking about AI for health.
Yeah, thank you for your questions. Honestly, talking about tech in health is one of my favorite things to do. So I can talk and talk and talk and talk and talk. So siloed systems, I think your question and her question are kind of tied, because that's what you're describing is exactly what siloed systems are. There's data collected among the community level, there's data collected when you go to a clinic, there's data collected when you actually start like your hospital visits, then there's data at the registry level, which is like just population based, where this person was recorded to have this type of cancer on this day, like it's just a summary. And then there is what is sent to Ministry of Health as aggregated data. So Ministry of Health only have visibility to there are 5 malaria cases in Kiambu County on this week. But can they be able to trace back these 5 malaria? It would mean going to the facilities where this was collected, then finding the actual files for these patients to get their names, to get their phone numbers, to get their homes. Okay? So that would be the chain. So I'll tell the answers now for these 2 questions. Where is innovation? Where is initiation? What is creation? My biggest principles when it comes to tech is do not reinvent the wheel. Don't start from scratch. I could come in as the Gen Z that I am into the system and say, you know what, scrap everything. Let's start from scratch. Let's design this thing already from ground up, right? There is benefits of that. There's risks to that. There's how much effort that will take, how much time in terms of how much effort in terms of time, money, knowledge, the everyday experience that I'll collect along the journey. So I shy away from creating something new. The beauty with the digital health space is there's a lot of open source recommendations. So for example, for this particular scenario, I'll leverage on one called OpenHIE, which is Open Health Information Exchange. And essentially what this does is describe an architecture where data should be able to flow through all these systems to have meaningful insights at all stages. So answering the question of do we have hope, how do we streamline this, there is actually hope and there is work that the government has done on this as well. If I had my laptop here, I could demonstrate, but maybe on your free time you could go and search the Kenya National Digital Health Superhighway, which is a comprehensive health management information system that has been developed by the Kenyan government based off of OpenHIE. So you see, in this, to answer this, we're not inventing something from scratch. We're picking an architecture or a design architecture that has been proven to work, and then contextualizing that to our setting. So essentially, what the digital health superhighway is it describes how data is supposed to flow within digital health in Kenya. So there's patient level data, there's insurance health level data, there's facility data, there's client clinician data, so that we have a way of exchanging all of this information. Because as IntelliSoft, there's no way, let me say there's no way, but we don't have any mandate to go knocking on Aga Khan's door and be like, we need all your patient data, you see? But if there's a way where Aga Khan Hospital can send their data to a national sort of data data hub, then Intellisoft can be able to pick from this data hub what I need to build my solution. So yeah, I would encourage maybe all those who are interested to look up the digital health superhighway. It kind of answers our data question. It's still in development. I wouldn't say it's very mature. And also, we still have to think about access to this national data hub. Is it probably there'll be costs involved? You know, government has to make money. So if it's run by government, maybe there'll be a cost involved to access this data. There is also authorization and security and what have you, and in terms of developing a way to tie one patient across multiple systems. So there are a lot of technical things to think about, but it exists. So I guess we have like 60-70% hope. Yeah, and then for SHA, yeah, Gen Z as I am, I feel like I'm scared to answer this question. Yeah. How much? I think, thank you so much, Dr. Paul, for coming before me and saying that, because that kind of answers the question. Tech goes more than just building the system. I think if you, as rightfully said, if you put 5 minds in a room somewhere and give them a deadline that they needed to build insurance pre-authorization system, because that's exactly what SHA is, being able to pre-authorize patients when they're coming to clinic, that they are credible for the insurance to pay, right? That's kind of what SHA is supposed to be able to do. If you put people in a room and give them that as like as a deliverable and define what the system needs to have, and it's buildable. We can build 101 versions of SHA, and everyone will argue why they're at it. It's like building a house, right? We can have 5 teams building houses, and they will not all look the same, and everyone will argue why their house is better in terms of functionality and maybe cost. But then at the end of the day, is we need to be able to pick the right thing for our people, right? For the patients at the end. What are the current gaps in the SHA system? I'm not viewed to what happens in the back end. I don't know what happens in the back end of SHA. I can guess. I can make an informed guess on what the problem is. I think they have a scaling issue. I think they have an authorization issue. They probably have a server downtime error. Like, they have many technical issues, which, yes, the technical issues can be easily solved, but I think it goes back down to what Dr. Paul has said, the person calling the shots.